Alright guys, the last lecture in the elbow differential non-operative diagnosis series is compressive neuropathy disorders. And so we know the elbow has a lot of different neurovascular structures that course through it. And so we'll get into some of the most common types of compressive neuropathies in the elbow. First, we just need to understand the myotomal and dermatomal pattern of the nerves that course through the upper extremity. And so you need to understand the radial nerves, dermatomal pattern, median nerve, and ulnar nerve, and the nerve roots that they innervate. Because this is where we're going to see, especially at the elbow, you're going to see the dermatomes represented in the hand, should I say peripheral nerve distribution rather than true dermatomes. But anyways, you guys need to review that and what areas would indicate which nerve. And so the three compressive neuropathies we're going to go over that are located at or about the elbow and forearm is the Cubital tunnel syndrome, which involves the ulnar nerve, the Pronator syndrome, which involves the median nerve, and radial tunnel syndrome, or radial nerve neuropathy rather, which of course is the radial nerve. So let's talk about the cubital tunnel syndrome. The cubital tunnel is a passageway for the ulnar nerve as it passes the elbow to enter the forearm, and this tunnel lies posterior to the medial epicondyle of the humerus. And so if you think about your medial epicondyle and your olecranon, really the cubital tunnel is right here in between those two spaces, and that makes up your quote-unquote funny bone. So if you ever hit that area, you know the ulnar nerve lives there. You have a tingling sensation go down to your fourth and fifth digits. The ulnar nerve can get trapped at a couple different sites. One is the medial humeral groove. One is the arcade of Struthers, which is a little more proximal than that. And then one is the medial intramuscular septum of the flexor carpi ulnaris. So cubital tunnel syndrome, some hallmarks here are night pain, sensory changes on the volar aspect of digit 5 and ulnar aspect of digit 4, hand clumsiness or weakness, symptoms change with elbow position or pressure over the cubital tunnel, and reproduction of symptoms during clinical exam. You need to differentiate here if it's more proximal or distal, because presentation is going to be in the hand typically, and so there's other entrapment sites, especially down at the wrist, that may cause similar symptoms as well. So you need to differentiate there. So signs and symptoms here. Basically what you see on the right is a picture of a claw hand or bishop's hand deformity. And then what you see at the bottom picture is muscle atrophy. And see the thenar eminence has atrophied compared to the opposite side. This is a picture. Some of the hand intrinsic muscles have wasted away, as well as the thenar eminence, of course. So numbness, tingling, burning are some of the main signs and symptoms. Hand weakness, clumsiness, etc. These are both severe cases here. So what are possible contributing causes for cubital tunnel syndrome? One is prolonged pressure on the cubital tunnel, particularly with elbow flexion, such as working at a computer. I'll also actually myself get this driving with my arms up on the kind of the armrest at the window as I'm driving here. Sometimes my hand will go numb, and it's because I'm on the ulnar nerve. And so that's one way as well. So could have bony abnormality of the humerus, could have a shallow ulnar groove, and then of course repetitive stress and microtrauma to the nerve. So this would be things like throwing because of the tensile forces through the medial elbow. The nerve can get stressed as well and give you neuritis, which is cubital tunnel syndrome. And so differential diagnoses are all things you guys need to be able to differentiate. So when we get into the wrist section, we'll go over what Guillen's canal is and distal ulnar nerve entrapment there. So What are some tests and measures we can do? Well, we have the elbow flexion test, which is picture top left. You literally just hold your elbow in a flexed position for up to 3 minutes. You can also add in wrist extension and radial deviation. And so those will put more strain or stress through the ulnar nerve. Wartenberg signs is picture the top right. It is a at rest abducted fifth digit. And then Froment's sign is an ulnar nerve test. This is a positive test when your thumb flexes, because what we want to see is that your thumb abduction is good, which is an ulnar nerve test, right? Strength. And so if you cannot grasp a piece of paper with a flat thumb and you want to perch up like this, you're using, in that case, median nerve to try to compensate for a lack of ulnar nerve innervation and strength. So there you have it. And then any sensory changes in the C8, T1 dermatome pattern. Also, I have muscle weakness of the following muscles listed here. What are some interventions you can do? Well, one is nerve slides, which you see pictured here. But really, it's activity modification is the big thing, and it's a big common theme with the elbow and really the shoulder too. Is you have to cease aggravating activities, and then once your body has helped yourself heal to some extent, then you can start loading more. In extreme cases, they'll do something like a ulnar nerve surgical decompression, or they'll transpose or move the nerve anterior to the medial epicondyle. That's called an ulnar nerve transposition. Do it in baseball players a lot, and boxers and things like that. So next up is Pronator Syndrome, and so move on to this next slide here. It's an overuse injury of the forearm that results in neuropathy of the median nerve due to its compression as it passes between the humeral and ulnar heads of the pronator teres. And so you can see this schematic on the right. This individual is palpating the pronator teres with concurrent wrist extension to put strain through the median nerve, both in a compressive manner and a tensile manner. And so people who get this syndrome are usually because of sports or work activities that involve forceful, repetitive forearm pronation. For example, weightlifting, baseball, racket sports, carpenters, assembly line workers, etc. And so signs and symptoms here are pain and paresthesia from the anterior forearm, exaggerated and applied pressure to pronator teres. Lateral aspect of the palm, including proximal part, lateral 3.5 fingers. Nocturnal pain is uncommon. Carpal tunnel, nocturnal pain is common. It's one way to differentiate with median nerve. We'll get into carpal tunnel syndrome in the hand lectures. So motor deficits, you'll have reduced grip strength and then weakness in some of those muscles listed there. Of course, functional implications are just that. Pain and paresthesias and then grip may be limited. So differential diagnosis includes anything that might involve the carpal tunnel, which is, the median nerve rather, which includes carpal tunnel syndrome, cervical radiculopathy, and medial epicondylalgia. And this picture on the bottom left is a good example of how to test. One is a Tinel sign, so actively tapping or pressure on the median nerve distribution. The Phelan maneuver, if you look at the top right of the screen, is not provoking symptoms. So isolated wrist position does not bring this on. This would be more indicative here of carpal tunnel syndrome. And so carpal tunnel tests do not bring this on. So something else is up, and that's how you would help diagnose this. Resisted pronation also can bring on those paresthesias. What do we do for intervention? Well, just like ulnar neuritis, activity modification. It's a big one. And so you start slow and you build up over time. get rid of the aggravating activities, and you then restore flexibility, strength, etc. So easy for me to say, harder to do in practice. And yeah, compressive neuropathies are tough cases, but activity modification usually does them a world of good. So let's get into the final one here, radial nerve pathologies. And so this has been commonly known as radial tunnel syndrome. However, there are 4 radial nerve entrapments possible. One is called a high radial nerve palsy. That'd be a radial nerve compression injury that's in the mid shaft of the brachium, which is the upper arm. We'll look at that a little bit. One is called posterior interosseous nerve syndrome, or PINS. One is true radial tunnel syndrome, and then also a superficial radial nerve palsy, which we won't get into that detailed. But here's important factors to note. There is motor and sensory involvement with the high radial nerve palsy. There is only motor involvement with the PINS, posterior interosseous nerve. There is pain, tenderness, and cramping in the proximal dorsal forearm with radial tunnel syndrome, and there are sensory disturbances with the superficial radial nerve palsy. So, sensory changes only in radial tunnel syndrome. That's opposed to PINS, which is posterior interosseous nerve syndrome. Both involve the radial nerve. PINS involves motor. RTS involves sensory. It's important to know the difference between those two. Rest pain and night pain are both common. So some demographics here is radial nerve entrapment coexists with lateral epicondylitis in 5% of patients. Anterior interosseous nerve syndrome is rare, accounting for less than 1% of the upper extremity neuropathies. This is most common in the 5th decade of life. Signs and symptoms: you're going to have burning, aching pain in the dorsal forearm, exaggerated by repetitive activity in the forearm pronation with wrist flexion, including things like screwdriver, typewriter, computer, keyboard, and handwriting. Pains reported over the anatomical snuff box and dorsal thumb. Grip strength is weak due to pain. So what this picture on the right is showing is the radial nerve coming down. You can see here it branches off and goes deep to the pronator. And this is the posterior interosseous nerve there. Here's that picture I was telling you about that is a good schematic. So this is at the axilla. If you have radial nerve injury at this area, then everything down the chain is going to be affected. So you have weakness and you're going to have sensory changes, right? Same thing goes when it's in the spiral groove of the humerus. Everything down the chain is going to be either weak or have sensory changes. When you get down here, the posterior interosseous nerve, you have muscle weakness and an inability to extend one's fingers. And so you can see how that would be an issue, obviously. Motor. Possible contributing causes is repeated exposure to severe cold. And so I don't have that up here in Minnesota. I wear a nice warm jacket, nice thick leather gloves. No radial nerve symptoms. But genetic structural factors, tumors or lipomas, direct trauma or blows to that area, impaired circulation of peripheral nerves, as seen in things like diabetes, may cause symptoms here. Differential diagnosis, you have a laundry list of stuff that mimics this, so understand it. What do you do for tests and measures? And really this is true for all of these nerve pathologies, is we can do things like a nerve conduction velocity test to see if there is impedance in the electrical signaling of the nerve as it courses down the arm. But Tinel's test to the radial nerve, compression test to the radial nerve, those are both two things you can do. Intervention, again, activity modification. You're going to look at ergonomics. You're going to look at avoiding aggravating activities. And then finally, nerve glides, strengthening, stretching, etc. In summary, we have a couple slides here that I think you guys need to pause or really study, okay, or screenshot. This is the nerve distribution in the upper extremity. It's important to know where anatomically different nerves innervate because it helps you diagnose maybe what's going on. And so one way, and this is just a sidebar, to impress a physician that you meet at your first job is to understand where nerves innervate different patches of skin and or different muscles. So don't forget about the nerves, okay, very important. This slide is looking at mainly the median nerve. As you can see here, it's a nice slide that goes over the anatomy as well as where you may have pain and what things may bring on the pain. Here is a slide on the radial nerve. Radial tunnel syndrome is mentioned here, and also gives you a nice anatomical picture. Just a really solid slide. So you can pause it here as well. Finally, your ulnar nerve slide. And so similarly, great anatomy picture, has some illustrations on how compression may take place with elbow flexion, which is why the elbow flexion test seems to elicit symptoms. You can see where it gets compressed here in the cubital tunnel. And so, great pictures for the visual. I want to thank you guys again for allowing me to teach you guys remotely, and can't wait to meet you in a few weeks here in person. Please send questions. I'd love to help you out. Thank you.